So the next topic which we are going to deal is head and neck today. Head and neck as well as neuroanatomy, will deal it all together. So the first topic in head and neck which I would like you to know is the cranial foramens. Now talking about cranial foramens, we'll see each and every cranial foramen and the structures which are passing through it. Okay, please be with me, note it down. The first one which we are going to talk is about the cribriform foramen. Okay, it may take a little time, but if you are listening properly, you will get to know the cribriform. Now, remember that these are the numerous perforations in the cribriform plate of the ethmoid bone. The cribriform foramens are basically nothing but these numerous perforations in the cribriform plate in the ethmoid bone. And this is the foramen that connects the anterior cranial fossa, anterior cranial fossa with the nasal cavity, with the nasal cavity. Remember, this is important. Okay. Now, these foramen, that is cribriform foramen, allows the passage of axons of olfactory bulb. In the last class, when we dealt with the cranial nerves, we have already said that the olfactory bulb and the olfactory nerve, they come from the cribriform foramen. So these foramen allow the passage of the axons of olfactory nerve, and that too from the olfactory epithelium of the nose and into the anterior cranial fossa, where we have the olfactory bulb. So the olfactory nerve from the cranial, from the cribriform foramen, they enter into the anterior cranial fossa to join or to communicate with that of the olfactory bulb. So what is the content of cribriform foramen? If someone is asking, that is the olfactory nerve. Olfactory nerve. So coming to the second one which we are talking is about the optic canal, about the optic canal and its foramen. Now coming to it, optic canal permits the passage of optic nerve. As the name goes, optic canal, it helps in the passage of optic nerve. Plus, it helps in the passage of ophthalmic artery. Important one. Okay, these are the two contents of optic canal and foramen. So what does it help in the passage? That is the optic nerve as well as the ophthalmic artery. Remember this. Okay. Now next one we are talking about is the superior orbital fissure. Superior orbital fissure. Now this is basically a cleft that opens anterior into the orbit. And this actually helps the communication between the cavernous sinus and the apex of the orbit. Important. Okay. Now, this helps in the transmission of several structures. I'll mention one by one. First one is the lacrimal nerve. Lacrimal nerve. Next one we have the frontal nerve. Lacrimal nerve and frontal nerve. Now remember these both, lacrimal nerve and frontal nerve, they are the branch of ophthalmic nerve. That is the first division of trigeminal nerve. Okay, the third content or third structure which is passing is the superior ophthalmic vein. Fourth one, we have a trochlear nerve. Then we have a superior division of oculomotor nerve. Then we have nasociliary nerve. Again, nasociliary nerve is a branch of ophthalmic nerve, lacrimal, frontal, and nasociliary nerve, which are basically nothing but the branch of ophthalmic nerve, the first division of trigeminal nerve. Okay, next one is the inferior division of oculomotor nerve. Then we have abducens nerve and a branch of inferior, sorry, inferior ophthalmic vein. These are the structures that are passing through the superior orbital fissure, and they are lacrimal nerve, mentioned over here, lacrimal nerve, frontal nerve, superior ophthalmic vein, trochlear nerve, superior division of oculomotor nerve, inferior division of oculomotor nerve, nasociliary nerve, abducens nerve, and a branch of inferior ophthalmic vein. So these are the structures that are passing through superior orbital fissure. So these three we have already seen: cribriform foramen, optic canal and foramen, as well as superior orbital fissure. So see over here, superior orbital fissure is this one, optic canal. And what is the other one which we saw? We saw cribriform. This cannot be seen over here because that is in the ethmoid bone, right? Okay, now next one we are going to deal with this, the foramen rotundum. Foramen rotundum. Now, this is located in the base of the greater wing of the sphenoid. Now, what we have to know is it provides a connection between the middle cranial fossa and the pterygopalatine fossa. Important one to know. Okay, and what is the content of, or which structure passes through foramen rotundum? Nothing but the maxillary nerve. And maxillary nerve is a branch of trigeminal nerve. Okay, so maxillary nerve passes through foramen rotundum. Next one we're talking about is foramen ovale. Important. Foramen ovale. Now, this is another opening located at the base of the greater wing of the sphenoid. So, these two are located in the base of the greater wing of the sphenoid bone. Okay, now, which particular nerve or which particular structure passes through foramen ovale? So, if it asks, you have to write as mandibular nerve. Mandibular nerve passes through foramen ovale. Again, this is a branch of trigeminal nerve. Apart from mandibular nerve, we have one more nerve, one more artery that passes, that is accessory meningeal artery. Accessory meningeal artery. So these are the two structures that passes through foramen ovale. Okay, so in the questions, what in the previous year question papers, what they have asked is the structure that passes through this particular foramens, and you have to choose among those. Okay, so sixth one we are going to deal with this internal acoustic meatus. Okay, now internal acoustic meatus is nothing but a bony passage located within the petrous part of the temporal bone. I repeat once again, it is a bony passage located within the petrous part of the temporal bone. And this uh, internal acoustic meatus, it connects the posterior cranial fossa and the inner ear. Okay. Now, what are the structures that pass through internal acoustic meatus are facial nerve and the vestibulocochlear nerve. These are the two structures that pass through internal acoustic meatus. The next one, what we are going to see is the jugular foramen. Now, talking about jugular foramen, this is basically formed anteriorly by the petrous part of the temporal bone, and posteriorly it is formed by the uh, occipital bone. Now, we have three compartments of jugular foramen. First one is anterior one, we'll see first. The anterior one, it contains the inferior petrosal sinus. We have a middle one. It transmits one particular nerve, that is glossopharyngeal. Glossopharyngeal nerve. Then we have vagus nerve. Also a little, that is a cranial part of accessory nerve. Cranial part of accessory nerve. And lastly, one more part is there, that is the posterior one. Talking of posterior, it usually contains the sigmoid sinus, and it transmits, what it transmits? It transmits meningeal branches. Remember, meningeal branches of occipital and ascending pharyngeal arteries. So once again, I'll repeat, the jugular foramen, it has three separate compartments. Okay, the first compartment, that is the anterior compartment, will be having, or the content is the inferior petrosal sinus. The second one is the middle part. In middle compartment, it transmits the glossopharyngeal nerve, the vagus, and the cranial part of accessory nerve. Lastly, we have a posterior compartment. It contains the sigmoid sinus as well as transmits the meningeal branches of occipital and ascending pharyngeal arteries. Okay, now next one we'll see is the hypoglossal canal. Hypoglossal canal. Okay, now this is located exactly in the occipital bone, and as the name goes, it helps in the transmission of hypoglossal nerve. Okay, next one, few other foramens. We have foramen magnum, and this is the largest, remember, the largest cranial foramen. The largest cranial foramen is foramen magnum. It lies in the occipital bone within the posterior cranial fossa, and it helps in the passage of medulla and meninges, plus vertebral arteries, also anterior and posterior spinal artery, plus dural vein. See, we have already said it is the largest cranial foramen, So we have a lot of contents, maybe medulla, meninges, the vertebral arteries, the anterior or the posterior spinal arteries, as well as the dural veins. Okay. Now, there are other things also. The spinal division of the accessory nerve ascends to the foramen magnum to join the cranial division. So one more thing in addition to this is accessory nerve. That was spinal division of the accessory nerve. That was about foramen magnum. We are coming to the last foramen. That is foramen spinosum. Now this is located within the middle cranial fossa, and that will little laterally to the foramen ovale. Now what it allows to pass? It allows the passage of middle meningeal artery, also middle meningeal vein, and the meningeal branch of, I'll write middle meningeal vein, also meningeal branch of the cranial nerve 5, fifth the cranial nerve. So this was regarding foramen spinosum. So totally how many cranial foramens we have? We have 10 cranial foramens. 10 cranial foramen. So remember this. So this was all about cranial foramens. So you can see the picture over here. We have optic canal, we have a foramen rotundum, foramen ovale, we have jugular foramen, hypoglossal canal, foramen magnum, internal acoustic meatus, then foramen spinosum, superficial orbital fissure. We had even had a cribriform fissure also. Okay, now next one is the nerve supply of the face. Nerve supply of the face. We have already dealt actually with all this, but this is again a brush up of whatever we have read. So talking about the nerve supply of face, before that you need to know a little about the the attachments of the uh, each nerve. Okay. So again we'll deal with this and then we'll go it. So the nerve supply of the face, all the muscles of the facial expressions, remember, all the muscles of the facial expressions are supplied by facial nerve, except the levator palpebrae superioris, and that is supplied by the third cranial nerve, and that is the oculomotor nerve. Okay, and sensory supply to the face is by trigeminal nerve. Is supplied by the trigeminal nerve, except the skin over the angle of mandible. And the skin over the angle of mandible is supplied by the greater auricular nerve. This is something which you need to remember. Now let us see the muscles which helps in the facial expression. So the muscles are divided as orbital, nasal, and oral. Okay. Now let's see the orbital group. Okay. Orbital. The first one here we're going to deal with is the orbicularis oculi. What is the action we'll see over here? We have three kind of orbicularis oculi. We have a palpebral part, we have a lacrimal part, and we have a orbital part. Okay, three different functions. So the orbicularis oculi, palpebral part, it helps in gently closing the eyelid. Now, lacrimal part, as the name goes, helps in drainage of the tears. And orbital part, it helps in tightly closing the eyelids. So palpebral part and orbital part helps in the closing of the eyelids. One helps in the gently closing of the eyelids, and the other one helps in the tightly closing of the eyelids. And what is the innervation? The nerve involved is the facial nerve. Now coming to the next one, that is corrugator supercilii. Okay. Now the action is to draw the eyebrows together. We frown. We draw the eyebrows together. Okay. And because of that, what happens? We can see wrinkles on the bridge of the nose. Okay. So what is again the nerve supply? That is again facial nerve. So remember, this is the orbital part I am telling about. Okay. Now, sorry. Next one we're talking about is the nasal part. Okay, nasal part. In the nasal part, one, the first muscle is nasalis. Nasalis. Okay, this nasalis is the largest nasal muscle. Remember, largest nasal muscle. Okay, one, there are two parts of nasalis actually. One is the transverse part and one is the alar part. I'll write over here. Transverse and alar. They exactly have two opposite functions. The transverse part helps in compressing the nares, whereas alar part helps in the opening the nares. Which muscle? Again, facial nerve. Which nerve? Sorry, again the facial nerve. The second muscle in the nasal part of face is this is procerus. Procerus. Okay. Now this helps in the contraction of this muscle. And because of that, it helps in pulling the eyebrow downwards to produce transverse wrinkles on the nose. So remember, action I'll tell you. It helps in the contraction. Procerus, no? When the contraction of this muscle happens, this pulls the eyebrows downwards. And because of that, there will be transverse wrinkles on the nose. Nerve innervation, again, it is the facial nerve. The last muscle of the nasal part is depressor septi nasi. Depressor septi nasi. Okay. Now, this will pull the nose inferiorly. And because of that, it will help in the opening of the nares. Opening of the nares. Again, supplied by the facial nerve. So these are the few muscles of orbital part as well as the nasal part. So remember, orbital part, we have a orbicularis oculi. Then we have corrugator supercilii, as well as in the nasal part, we have nasalis, procerus, as well as the depressor septi nasi. Okay. Now, I'll try writing the oral part here only. Okay. For oral. The first muscle in the oral part we are going to deal with is orbicularis oris. Now, what it does? It purses the lip. Purses the lip. And which muscle? Sorry, which nerve? It is a facial nerve. The second muscle in the oral group is the buccinator. Buccinator. Okay. Now, buccinator, I will not write over here the action. Please listen to me. Buccinator, actually it helps to pull the cheek It helps to pull the cheek inwards against the teeth, like doing a whistle. Okay, so buccinator pulls the cheek inwards against the teeth, and the innervation is by the facial nerve. The third muscle in the oral group there are a few other. There is a lower group and the upper group. I'll not write over here. Please listen to me carefully. The lower group contains the depressor anguli oris, depressor labii inferioris, as well as the mentalis. Okay, and upper group we have risorius, zygomaticus major, zygomaticus minor, levator labii superioris, levator labii superioris aliquid nase, as well as levator anguli oris. Now, these muscles, these all the lower group and the upper group, which I just said, they act on the lips and the mouth. Remember, they act on the lips and the mouth. Okay. Now, what is the clinical relevance to all these oral muscles? Uh, that is paralysis of the oral muscles. If at all the facial nerve is dysfunctional, we have seen facial nerve, right? All here. So, if at all the facial nerve is dysfunctional, the oral muscles can become paralyzed. Okay. And what happens if the oral muscles become paralyzed? There will be difficulty in eating the food with collecting, and the food should be collected in between the teeth and the cheeks, right? All those functions will be even lost or damaged. So this was regarding the nerve supply of the muscles and the muscles of the face. Okay. Now, next one we are going to deal with is the muscles of mastication. Muscles of mastication are four in number. Okay. The first one is masseter, the temporalis, and the pterygoid. There are two pterygoids, the lateral part and the medial one. The masseter, temporalis, and the pterygoid. Pterygoid are two, that is lateral and the medial one. The nerve supply to the muscles of mastication is the mandibular nerve. Mandibular nerve supplies the muscles of mastication. And the muscle responsible for depression of the mandible. Depression of mandible means opening the jaw. That is the lateral pterygoid. The lateral pterygoid muscle is responsible for the muscle for the depression of the mandible. Okay. Now, accessory muscle of mastication. This was asked many times. Which is the muscle which is known as the accessory muscle of mastication? Remember, that is buccinator. Buccinator is the accessory muscle of mastication. Now, the most common muscle involved in the trismus, that is a lockjaw, is the medial pterygoid. Okay, remember for depression of the mandible, that is opening the jaw, lateral pterygoid is responsible. And if at all there is a lockjaw or a trismus, we should know that the muscle which is responsible for it is the medial pterygoid muscle. Once again, I repeat, the muscles of mastication are masseter, temporalis, and there are two pterygoids, that is the lateral and the medial pterygoid. Okay. Now, there are few extrinsic muscles of the tongue. Now, we are talking about the muscles of the tongue. The extrinsic muscles of the tongue are glenoglossus, which is otherwise termed to be the safety muscle of the tongue. And it is the largest muscle of the tongue. Okay. The glenoglossus muscle. Styloglossus muscle, we have a palatoglossus muscle, which is not exactly the true muscle of the tongue. And then we have a hyoglossus muscle. Hyoglossus muscle, palatoglossus muscle, styloglossus muscle, as well as the genioglossus muscle. So this was regarding the extrinsic muscle. So when there is an extrinsic muscle, so definitely there should be a intrinsic muscle. And talking about intrinsic muscle, we'll see which are they. Okay. Intrinsic muscles of tongue. Now, these muscles attach to the other structures in the tongue. Like there are four paired, remember, there are four paired intrinsic muscles of the tongue. And however, the direction in which they travel, no, according to that only their names are being told. So the first one we're talking about is superior longitudinal. Then we have inferior longitudinal. Then third one, we have a transverse. Fourth, we have vertical muscles. So these are the intrinsic muscles of the tongue. These are the muscles, that these four muscles are the ones which affect the shape and the size of the tongue. This affect the shape and size of the tongue. Suppose if you want to roll the tongue, these are the muscles which will help you. And the motor innervation of these muscles, that is intrinsic muscles, are hypoglossal nerve. Remember, hypoglossal nerve. Okay. Now, coming to we'll go back to the extrinsic muscles. Now, the extrinsic muscles, the first one was the genioglossus muscle. We'll see a little about genioglossus muscle over here. The inferior fibers of the genioglossus muscle, okay, and the middle fibers, the inferior and the middle. I'll write over here. Inferior and the middle, they have one function, and that is depressing the tongue. They help in the depression of the tongue. Whereas the superior fibers, they draw the tip back and down. They draw the tip of the tongue back and down. Okay. So nerve supply, I'm mentioning here only. The first one, glossus, is supplied by hypoglossal nerve. Hypoglossal nerve. Okay. Next one is the styloglossus. Let's see what styloglossus does. Styloglossus helps in the retraction and elevation of the tongue. Retraction and elevation of the tongue. Again, what is the nerve supply? It is by hypoglossal nerve again. Next one, coming to the hyoglossus. This one depresses and retracts the tongue. And what is the nerve supply? Name is hyoglossus. So it is hypoglossal nerve. Last one is palatoglossus. Now palatoglossus is, the function is, it helps in the elevation of the posterior aspect of the tongue. Posterior aspect of the tongue. And remember, palatoglossus is supplied by vagus nerve. So all the three muscles like genioglossus, shyoglossus, and the hyoglossus are supplied by hypoglossal nerve, but palatoglossus is supplied by the vagus nerve. This is very important. Except for the palatoglossus, there's every muscles of the tongue are supplied by the hypoglossal nerve. Palatoglossus nerve is been supplied by the vagus nerve. Now when we are talking about tongue, let's see the vasculature of tongue. Vasculature of the tongue. So which artery is supplying the tongue? So remember, we have two arteries. One is the lingual artery. Remember, lingual artery is the one which supplies most of the majority of the supply is by lingual artery. Okay, but we even have tonsillar artery, which is also supplying. Okay, now this helps in some kind of collateral circulation. Collateral circulation. Lingual artery supplies majority parts, and tonsillar artery helps in the collateral circulation. And the drainage is by, remember, drainage is by lingual vein. Lingual vein. So this is something which you need to remember in case of tongue. The vasculature is by lingual artery and tonsil artery. Majority is by lingual artery. Tonsil artery helps in collateral circulation. And the drainage is by lingual vein. This is something which you need to remember about the tongue. So the next topic which we are going to, this is already I mentioned. Once again, I'll brush up the muscles. Hypoglossal nerve, except hypoglossal nerve supplies all the muscles except for palatal-glottis, that is the vagus nerve. All the muscles of the larynx, the recurrent laryngeal nerve, except for cricothyroid muscle. This I have not said. The muscles of the larynx, that is it is supplied by recurrent laryngeal nerve, except for the cricothyroid muscle. When we are talking about the larynx, the organ classes, we'll see. But you should remember which is the nerve that supplies to the muscles of the larynx. So remember, muscles of the larynx have been supplied by the recurrent laryngeal nerve, but except for the cricothyroid muscle. Cricothyroid muscle is supplied by the external laryngeal nerve. Okay, now talking about the pharynx. All the muscles of the pharynx are supplied by vagus nerve, except for two muscles, cricopharyngeus muscle and stylopharyngeus muscle. Remember, cricopharyngeal muscle is now supplied by recurrent laryngeal nerve, but the stylopharyngeus muscle is supplied by the glossopharyngeal nerve. Okay, once again, I'll repeat. This is the uh, muscle innervation, the nerve innervation to all the muscles. Muscles of the tongue we have already dealt in detail. It is palatal glossus by vagus and the rest everything by hypoglossus. All the other extrinsic as well as the entire intrinsic by hypoglossus. Larynx muscle, that is recurrent laryngeal nerve, supplies all the muscles except for cricothyroid muscle that is being supplied by external pharyngeal nerve. These are, if just points to remember. At a glance, you should remember all this. So all the muscles of the pharynx are supplied by vagus nerve except for cricopharyngeus muscle that is supplied by recurrent laryngeal nerve and stylopharyngeus muscle supplied by glossopharyngeal nerve. Okay. Now, all the muscles of the mastication is by mandibular nerve. We have already said here. Muscles of mastication by mandibular nerve. Next one, all the muscles of palate is supplied by vagoaccessory muscle. Remember, vagoaccessory muscle, except for tensor veli palatina muscle. And tensor veli palatina muscle, it is supplied by the mandibular nerve. Okay, so this is something which you had to know, and it is very important. This particular part is very important. If you want, you can take a screenshot of it and see. So now, coming to the extraauricular muscles. Okay, extraauricular muscles. We'll see which are they. So now, talking about the extraocular muscle. So before I go into detail of all these muscles, their action and the nerve supply, one thing which you need to remember is these extraocular muscles. Okay, they are actually located within the. Remember, they are located within the orbit. Okay, they're located within the orbit. That is one information which you need to remember. Okay. Apart from that, there are 7 ocular muscles. They are 7 in number, 7 ocular muscles. What are they? Which we have written over here. Levator palpebrae superioris, superior rectus, inferior rectus, lateral rectus, medial rectus, superior oblique, and inferior oblique. These are the things. Okay. Levator palpebrae superioris, superior rectus, inferior rectus, lateral rectus, medial rectus, and superior oblique and inferior oblique. Okay, these are the muscles. The rectus, the recti, and the oblique. Okay, these help in the eye movement. This help for the eye movement. But whereas the levator palpebrae superioris, they help in the superior eyelid movement. I'll write over here small. The recti and the oblique. This is a just I'm telling. They help in the eye movement of the eye. But whereas levator palpebrae superioris, they help in the movement of the eyelid, superior eyelid movement. Superior eyelid movement. Okay, now coming to the first muscle, levator palpebrae superioris. Remember, this is the only muscle involved in raising your superior eyelid. Okay. Now, It elevates the upper eyelid, and the nerve supply is the superior division of the oculomotor. Now coming to the superior rectus, I've already mentioned eye movements, right? So helps in the elevation of eyeball and adduction and intorsion of the eyeball. Adduction and intorsion of the eyeball. First one. Okay. Now, which nerve is supplying? And that too, superior division of oculomotor nerve. Now remember, except for the superior oblique, rest everything is being supplied by the oculomotor nerve. So not only superior oblique, sorry, lateral rectus also. So rest of the thing is being supplied by oculomotor nerve. Some are superior division, some are inferior division. So the two muscles which are supplied by the superior division of oculomotor nerve are levator palpebrae superioris and superior rectus. Other one, there is inferior rectus, medial rectus, and the inferior oblique. These are supplied by the inferior division of the oculomotor. Now, inferior rectus, it helps in the depression of the eyeball. It is just opposite to the superior one. Okay. Superior rectus, elevation of the eyeball. Inferior rectus helps in the depression of the eyeball. Superior rectus helps in the intorsion of the eyeball. Inferior rectus helps in the extorsion of the eyeball. Rest adduction is the same. Coming to the lateral rectus. Lateral rectus helps in the abduction of the eyeball, whereas medial rectus helps in the adduction of the eyeball. Lateral rectus is supplied by a different one, that is a abducent nerve. Abducent nerve. Okay. Medial rectus, we have already said, it is by the inferior division of the oculomotor nerve. Now coming to the superior oblique and inferior oblique, they are just opposite in terms of action. When superior oblique helps in intorsion, abduction, and depression, inferior oblique will help you in extortion, abduction, and elevation. Intorsion and extortion, depression and elevation. One different thing is superior oblique is supplied by trochlear nerve. Superior oblique is supplied by the trochlear nerve. Okay. Now, a little of the clinical relevance we'll see regarding the oculomotor, trochlear, and the abducent nerve with regards to the extraocular muscles. We'll see. First one is the oculomotor. Change the color. Okay. Now, if at all there is a lesion in the oculomotor nerve, this affects the extraocular muscles. Now, what will happen? The eye which has been affected is displaced laterally. Displaced laterally by the lateral rectus and inferiorly by the superior oblique. So because of that, the eye adopts a position known as down and out. This is one. If at all the problem is with the or damage is with the trochlear nerve, this will paralyze the superior oblique muscle. Okay. Now because of that, even the patient can even complain of diplopia and all that. Third one, if something happens to the abducent nerve, this will paralyze the lateral rectus muscle. And the affected eye will abducted by the resting tone of the medial rectus. It will get adducted. Okay, so this was regarding the extraocular muscle. Now to remember about the nerve supply, we all know there is another way, and that is LR6, SO4, R3. Remember this. So this was regarding the extraocular muscles. So the next one we are going to talk about is maxillary artery. Maxillary artery, an important topic. So something which you need to know about maxillary artery, I'm going to tell you with regards to the entrance examinations. So maxillary artery, we should know one thing, that it is a branch of external carotid artery. Remember, it is a branch of external carotid artery. And one more thing, this is the largest branch of external carotid artery. Not only just a branch, but it is the largest branch of external carotid artery. Now, with the help of lateral pterygoid muscle, the maxillary artery is divided into three parts. Now, when we're talking about the arterial tree, if you remember, subclavian artery, the axillary artery, all those were divided into three parts, right, with the help of a muscle. The same way, maxillary artery is also divided into three parts or three branches or three parts with the help of lateral pterygoid muscle. Let's see the first part and what are the branches. In the first part, the branches are accessory meningeal artery, anterior tympanic artery, deep auricular artery, middle meningeal artery, and inferior alveolar artery. These are the ones that passes through the first part, in which what becomes important for us in the point of view of exam is accessory meningeal artery will be passing through the foramen ovale, and the middle meningeal artery will be passing through the foramen spinosum. Okay, now remember, if at all there is a hemorrhage in the, or if a breakage in the middle meningeal artery, there will be epidural hemorrhage. Remember, epidural hemorrhage due to uh, the break of middle meningeal artery. Epidural hemorrhage. Okay, so this was about the first part of the maxillary artery. Next, coming to the second part. The second part, the branches, they remember, they supply to the muscles of mastication. Okay, now, two deep temporal artery we have, other one artery to masseter, artery to medial pterygoid, and artery to lateral pterygoid. Okay, remember these were the muscles of mastication. Okay, the next one is the third part. Third part, the branches are posterior superior alveolar artery, inferior orbital artery, greater palatine artery, pharyngeal artery, artery to pterygoid canal, and the sphenopalatine artery, otherwise known as the artery of epistasis. Sorry, this is an epistasis over here. Okay, now these are the branches that help in contributing the Little's area. Little's area, so these are the arteries. So alveolar artery, we have inferior orbital artery, greater palatine artery, pharyngeal artery, artery to pterygoid canal, and sphenopalatine artery, otherwise known as the artery of epistasis. Okay, so these are the parts of maxillary artery, and this is very important to know. Third part of maxillary artery helps in contributing the Little's area. Next one, this is very important. The pharyngeal or the brachial apparatus. This topic is very important with regards to exams. Every exams, no one question comes from here. So pharyngeal or brachial apparatus. Now we have pharyngeal cleft. We have pharyngeal clefts over here, and we have pharyngeal pouches. Okay, and these are the arches. Remember, we have 1, 2, 3, and 4. After that, fifth one is not there. We directly go to the sixth. Okay, but the fifth will remain as a remnant and will be present as an ultimobranchial body. Ultimobranchial body. Okay, now we have 1, 2, 3, and 4 pharyngeal cleft, and we have again 4 pharyngeal pouches. Okay, what you need to remember is the pharyngeal cleft, all these 4, are derived from the ectoderm, and the pharyngeal pouches, which you can see over here, are derived from the endoderm. And middle one, the pharyngeal arches, they are derived from mesoderm. They are derived from mesoderm. So here we have ecto, we have endo, and we have mesoderm. This is very important and you should know it. The next one, With regards to the pharyngeal arches and pouches or apparatus, remember the derivatives which we have to know. The first cleft, the derivative of the first cleft is external auditory meatus. Then all the three together, second, third, and the fourth cleft together helps in the derivation of they are incorporated into the cervical sinuses. Remember, the first cleft, from there we have the external auditory meatus, and second, third, and fourth cleft we have the cervical sinus formation. The first pouch is very important. We have the eustachian tube as well as the tympanic cavity. Second pouch helps in the derivation of palatine tonsil. Third pouch, we have inferior parathyroid as well as thymus glands. Fourth and the sixth pouch together, we have superior parathyroid and the ultimobranchial body. Ultimobranchial body is nothing but the fifth pouch. Okay, this is something which you need to remember, and it is very important with regards to examinations. I'll repeat once again. First cleft by the external auditory meatus. Second, third, and the fourth cleft, it is incorporated into the cervical sinus. Then first pouch, eustachian tube and the tympanic cavity. Second pouch, we have palatine tonsil. Third one, we have inferior parathyroid as well as the thymus. Fourth and the sixth pouch together, we have the superior parathyroid and the ultimobranchial body. So this was regarding the pharyngeal or the branchial apparatus. Now, some other things, the arches. So all this time we saw the derivatives of the pouches and the cleft. Now we are going to see about the arch. The first arch, the derivatives are the malleus, incus, the anterior ligament of malleus, the sphenomandibular ligament, and the mandible as well as the maxilla. So these are the derivatives of the first arch. And the nerve supply is by the mandibular nerve. Okay, muscles. All the muscles of mastication, the tensor tympani, the tensor veli palatinae, the anterior belly of digastric as well as the mylohyoid. These are the muscles which are derived from the first arch. The second arch, we have stapes, styloid process, stylohyoid ligament, and the lesser horn of hyoid muscle. Lesser horn of hyoid muscle. Okay. The nerve supply is by facial nerve. Muscles which are derived are muscles of facial expression, stapedius, posterior belly of digastric, and stylohyoid. These are the muscles. Third arch, that is a greater horn of hyoid muscle. And remember, the nerve supply is by glossopharyngeal. And the muscles which are involved are muscles which are derived are, now remember the muscles of larynx, pharynx, and the palate. They're not only derived from the third arch, but also third, fourth, and fifth, fourth and sixth. I have written all together. Muscles of larynx, pharynx, and palate. But the fourth arch, the derivatives are the cartilages of larynx, that is thyroid and the cricoid cartilage. Nerve supply of these are by superior laryngeal and the recurrent laryngeal. Muscles we already know, which are the muscles which have been innervated, that are muscles of larynx, pharynx, and the palate. Now this has to be read again and again so that it remains in your mind. The derivatives are very important. Okay, thus we'll come into the muscles of neck next. Muscles of neck, a very important topic this is. So coming to the muscles of the neck, the first one we'll talk about the cervical muscles. Now, in case of the cervical muscle, we have platysma and we have sternocleidomastoid. So then we have sternocleidomastoid. Platysma cannot be seen. Okay, there's a superficial one here. So platysma, basically a superficial origin is from the superficial fascia over the upper part of the deltoid and the pectoralis major. That is the origin of platysma. Okay, we will not deal with all the origins and insertions, but remember, most important ones which is usually asked in the exams are the nerve supply and the action. So platysma, the nerve supply is by the facial nerve. Now talking about facial nerve, there is one more muscle in case of for the muscles of the neck, and that is the stylohyoid muscle. The stylohyoid muscle is also being supplied by the facial nerve. You can see in the yellow one, yellow color, we have the stylohyoid muscle. The one in yellow over here, that is a stylohyoid muscle. Okay, so we'll see the platysma first. So facial nerve, and it helps in the depression of the lower jaw and the lip and the angle of the mouth. Also causes wrinkles, skin of the neck, wrinkling in the skin of the neck. So second one which we have is the sternocleidomastoid. You can see the sternocleidomastoid muscle. Okay, now this is being supplied by the spinal accessory nerve, and C2 to C8 are the sensory one. It The action of it is it singly turns the face towards opposite side. Together, flex the head and raise the thorax. Okay, so raising the head, flexion of the head, raising the thorax, and also turning the face to the opposite side. That is what the function of or action of sternocleidomastoid is. Next one, coming to the digastric, mylohyoid, stylohyoid, and genoid. Okay, so coming to the digastric first. Remember the posterior belly of the digastric muscle. Remember, this is digastric muscle. Here we have a posterior belly, and I'll write it in the show it here. Okay, so here we have the posterior belly, and here this is the anterior belly, the one in the green properly. Okay, so the posterior belly is by facial nerve. Posterior belly is by facial nerve, and the anterior belly is by trigeminal nerve. This is by facial nerve, and this is by the trigeminal nerve. Now it helps in the elevation of the hyoid bone and the floor of the mouth. And this one helps in the depression of the mandible. Depression of the mandible. Okay. So next one is the mylohyoid. Remember mylohyoid muscle, which has been shown here in this brown color. Okay, the brown. Here I will mark in some other color. So this is the mylohyoid muscle. The nerve supply of this muscle is the mylohyoid nerve of the trigeminal nerve. Okay, and this again helps in the elevation of the hyoid bone and the floor of the mouth and depresses the mandible. Okay, so basically the suprahyoid muscles, namely the digastric, the mylohyoid, the stylohyoid, and the genohyoid, helps in the elevation of the hyoid bone. Okay, elevation of the hyoid bone. These two, that is digastric and mylohyoid, will help in the depression of the mandible as well. Depression of the mandible. The stylohyoid only elevates the hyoid bone. Stylohyoid, I've already mentioned in the yellow color. Okay, that elevates the hyoid bone. And I've already said the nerve that supplies is the facial nerve. Next comes the genohyoid, the one in the blue. Okay, now genohyoid, it has been supplied by the one second. Yes, it is supplied by the C1, the cranial nerve 1, via the hypoglossal nerve. The one in the blue, this is the genohyoid muscle. This has been supplied by the C1 via the hypoglossal nerve. And this also elevates the hyoid and the floor of the mouth. So next, coming to the infrahyoid muscle. So remember, these were the suprahyoid muscles. Now coming to the infrahyoid muscles. Okay, now infrahyoid muscle, we have a sternohyoid, we have sternothyroid, we have thyrohyoid, as well as omohyoid. Okay, so first one, let's see about the sternohyoid muscle. Sternohyoid, which is given as a green color here. Once again, I'll show you the one in the green. This is sternohyoid muscle. Sternohyoid. This is supplied by the ansa cervicalis. Ansa cervicalis supplies the sternohyoid. It supplies the sternothyroid as well as the omohyoid muscle. Okay, and the basic function or action of these muscles of infrahyoid muscles are to depress the hyoid bone as well as the larynx. It depresses the hyoid bone and the larynx. Okay. Now, sternohyoid muscle, sternothyroid muscle again, it is being supplied by the ansa cervicalis, and also it depresses the hyoid bone as well as the larynx. Coming to the thyroid bone, thyroid muscle, thyrohyoid muscle, sorry, thyrohyoid muscle, the one in the uh, brown color, the one in the brown. This is red now, the one in the red right now, that is a thyroid muscle. This is supplied by the C1 via hypoglossal nerve, just like that of the genohyoid. Okay, and this one depresses the hyoid and elevates the larynx. Depresses the hyoid and elevates the larynx. A little difference from the other two. Last one, we have a homohyoid, the one in the blue color which has been given. Remember that homohyoid muscle is having two bellies. Here you can see a superior belly, one in the blue, and here this is the inferior belly, again in the blue. Okay, talking about the homohyoid, we have two bellies, a superior belly and the inferior belly. Okay, now the nerve supply to it is ansa cervicalis. Here I'll write, this is also ansa cervicalis. Okay, now coming to the action of homohyoid, it depresses and retracts the hyoid and the larynx. Depresses and retracts the hyoid bone and the larynx. These are the muscles of the neck. Once again, the cervical muscles are platysma and sternocleidomastoid. Then we have suprahyoid muscles and the infrahyoid muscles. The muscles that are included in the suprahyoid muscles are digastric, mylohyoid, stylohyoid, and genohyoid. Infrahyoid muscles are sternohyoid, sternothyroid, thyrohyoid, and the omohyoid muscle. This was regarding the muscles of the neck. Next one, we will deal in detail about the neuroanatomy part. Neuroanatomy. So talking about neuroanatomy, the first one, the first topic which we are going to deal with is the ventricles of the brain. A very important topic. The ventricles of the brain. Okay, now you can see the picture over here. This is nothing but, you can see the one in the blue. Okay, so these are the ventricles. There are two ventricles, then we have a third ventricle, we have two lateral ventricles, we have one third ventricle, and we have one fourth ventricle. And the location of these ventricles, this is important. This has come in few examinations. The two lateral ventricles are located in the telencephalon. The third ventricle in the diencephalon, and the fourth ventricle in the rhombencephalon. This is important. This is very, very important one. You have to remember. Okay, so the ventricles, the first one is two lateral ventricles. They are situated in the, are located in the telencephalon. Third ventricle, it is located in the diencephalon, and the fourth ventricle, it is located in the rhombencephalon. Okay, very important. Now here, the connecting the lateral and the third ventricle, what we have is a, you can see over here, these are the two lateral ventricles. This is the third ventricle, and this is the fourth ventricle. The one that connects these two, one that connects these third ventricle with that of the lateral ventricle, we term it to be a foramen of Monro. Foramen of Monro, otherwise termed as a interventricular foramen or foramen of Monro. What it does is, I'll write over here, it connects the third and lateral and the third ventricles. Next one, we have a connection between the third and the fourth one, and that we term it to be a cerebral aqueduct or aqueduct of Sylvius. Aqueduct of Sylvius. So cerebral aqueduct, otherwise termed to be aqueduct of Sylvius, is a connection between the third and the fourth ventricle. Okay. This is very important one. This has been asked many a times. So this was about the ventricles of brain. Remember, two lateral ventricle, one third ventricle, and the other one fourth ventricle. Okay. So connections between the lateral and the third ventricle, we term it to be foramen of Monro, otherwise interventricular foramen. And the other one connecting the third and the fourth ventricle is cerebral aqueduct or the aqueduct of Sylvius. The next one coming to the cerebrospinal fluid. Okay, now this has been formed, cerebrospinal fluid is formed by the choroid plexus of lateral ventricles. Lateral ventricles over here. From the choroid plexus of these lateral ventricles, we have the cerebrospinal fluid. Now, we need to know the rate of formation of cerebrospinal fluid. It can be asked whenever. So, rate of formation, that is 0.2 to 0.7 milliliter per minute, or per day if you talk, it is 600 to 700 milliliter per day. 600 to 700 ml per day, or 0.2 to 0.7 ml per minute. Specific gravity is 1007. The pressure, the cerebrospinal fluid pressure is 60 to 150 mm of fluid, or 60 to 150 mm of water. The total volume, which is, it is a range, that is 140 to 270. 140 to 270. So this is something about the rate of formation, specific gravity, pressure of CSF, as well as total volume of CSF. Now, coming to the composition of cerebrospinal fluid. Proteins, that is 20 to 40 mg per 100 cubic millimeter. Okay. Sugar, that is 50 to 75 mg per 100 cubic millimeter. Cubic centimeter, sorry. Cubic volume. Chlorides are 720 to 750 mg per 100, and cells are 0 to 5 per millimeter cube. So this is the composition. Proteins they have sugar, they have chlorides, as well as they have diffuse cells. Now, with regards to this, a little of the clinical aspect which you have to know is the lumbar puncture. Lumbar puncture is being done at the level between L3 to L4. Remember, L3 to L4. And the biochemical analysis of CSF, it is used to detect meningitis and few spinal tumors. Okay. Now, if at all there is an obstruction of the CSF in the ventricular system, if there is an obstruction, the patient can come up with hydrocephalus. Now, if at all there is a spinal obstruction or obstruction of the CSF in the spine, we have Freund syndrome. This is the few clinical aspects which you need to remember. Where we do a lumbar puncture, it is being done at the level between L3 and L4. Why do we do a biochemical analysis of CSF? To detect meningitis and spinal tumors. If at all there is a obstruction of the CSF in the ventricular system, what happens? We get a condition known as hydrocephalus. But if at all there is an obstruction of CSF in the spinal cord, what we have a Freund syndrome. So this is regarding the CSF, a very important topic. Next one, coming to the spinal cord as such. So coming to the spinal cord, we need to know the extent of spinal cord. Remember, the extent of spinal cord is C1 to L1. L1 lower border. Okay, lower border. This is in the adult. If you are talking about the neonates, this is C1 to L3. That to upper border of the L3. So this is something which you need to remember. So I'll repeat once again, extent of spinal cord. In adults, it is C1 to L1, and in neonates, it is C1 to L3. And the spinal cord ends in conus medullaris. Right? It comes like this. And finally, we have conus medullaris. And then, as a continuation of this, we have phylum terminal. Okay. Now remember, phylum terminal is nothing but the extension of the pia mater till the coccyx. Okay. Now, arachnoid matter and the fire matter in phylum terminal, they meet at S2. They meet at S2. And CSF is present in the arachnoid space. CSF is present where? It is present in the arachnoid space. Now coming to the cauda equina. They are bundle of nerves at the end. They are bundle of nerves at the end. Okay. Now, lumbar puncture, it is basically, we have already mentioned here, L3 to L4. Okay. But in some cases, they say a range that is L1 to S2. But the most appropriate uh, position where we can do a lumbar puncture is L3 to L4. Okay. Now, coming to the association fibers. Now we have three kind of fibers. One is association fibers, we have projection fibers, as well as we have commissure fibers. Yes. So we are talking about the association fibers now. Now, what are association fibers? Now, association fibers are something which connect the adjacent area of the same sphere. They connect the adjacent area of the same sphere. For example, there are few. There is arcuate fasciculus. Arcuate fasciculus. Okay. Now there is uncinate fasciculus also. Uncinate fasciculus. Remember, over here you can see it is connecting the adjacent area of the same hemisphere. Okay, cingulum. You can see adjacent area of the same hemisphere. Superior longitudinal fasciculus or bundle. We have an inferior longitudinal fasciculus or inferior longitudinal bundles. And then we have fronto-occipital fibers. So these are the examples of association fibers. Remember, so association fibers are arcuate fasciculus, we have uncinate fasciculus, cingulum, superior longitudinal bundle, inferior longitudinal bundle, and the fronto-occipital fibers. These are nothing but the fibers that connect the adjacent area of the same hemisphere. Same hemisphere. Okay. So next one is projection fibers. Now these connect the cortical area to the subcortical areas. Cortical area to the subcortical area. And the two things which you need to remember is the corona radiata and the internal capsule. You can see this is the internal capsule, the bundle, and corona radiata, they connect the cortex to the subcortex. You can see cortex to the subcortex. This entire thing is corona radiata. Okay, cortex to the subcortex. So these are the two things which you need to remember. Most important thing which you need to remember in projection fibers. Now next coming to the commissures. This is very important one. Okay, talking about the commissure. The largest commissure is the corpus callosum. Now, before that, we'll just see what is a commissure. That is the white matter of the brain that connects the right and the left half of the brain. So right and the left half of the brain. Okay, that connects. That is called a commissure. Now, the largest commissure is corpus callosum. Corpus callosum. The parts of corpus callosum is very important for you to know. One is a rostrum. You can see rostrum over here. Then we have a genu. We have a body. And we have splenium. These are the four parts of corpus callosum. Rostrum, genu, body, and splenium. What are the other commissures which connect the right and the left half of the brain? There is an anterior commissure. You can see anterior commissure. We have a posterior commissure here, habencular commissure, and a hippocampal commissure. Okay, hippocampal, habencular. You can over here. This part is actually the habencular, and then we have a hippocampal. Okay, so these are the four other commissures apart from the corpus callosum. Corpus callosum part is very important to know. Rostrum, genu, body, and the splenium. And corpus callosum is the largest commissure, which you should remember. Okay, so next one, coming to the tracts. So this is very important. You need to remember in, or when we are talking about the neuroanatomy. So let us first see what you mean by tract. The white fibers that connect the brain and the spinal cord, they are known as a tract. Okay. So the first one we'll see about the ascending tracts. Ascending tracts over here. We have dorsal column, medial lemniscus, that is you can see over here. Gracile fasciculus, we have cuneate fasciculus. Then we have two spinocerebral tracts, that is posterior and we have anterior. Then we have anterolateral system also, which contains the lateral spinothalamic tract and the anterior spinothalamic tract. Now, one thing you should remember the difference between the descending tract and the descending and the uh, ascending tracts are the dorsal column. The dorsal column will be always an ascending tract. Remember, dorsal column will be always the ascending tract. Okay. Next. So the first one we're going to deal here is about the okay, ascending tracts. The first one is the lateral spinothalamic tract. Remember, lateral spinothalamic tract. Now here, what is the function? And that is more important. The function of the lateral spinothalamic tract is, it usually, before that function, I'll tell you something. Lateral spinothalamic tract is, it basically carries the sensory modalities for pain and temperature. So because of that, you will feel the pain and temperature from the opposite side of the body. Remember, opposite side of the body. Now coming to the anterior spinothalamic tract, what it does? It carries the sensory modalities for crude touch and pressure. Crude touch and pressure. So what will happen? Light touch, pressure, tickling, and itch sensation from the opposite side of the body. That are the function. Now coming to the spinotectal tract. Now here we have visuomotor reflexes, head and the eye movements towards the source of stimulation. That is what is their function. It acts or it helps in the visuomotor reflexes, the movements of the eye, the movements of the head, as well as that movements of the head that too towards the stimulation. That is, someone gives us a noise and we turn our head or the eyes towards it. That is what happens in case of that is happens due to the spinotectal tract. Now, next one we have a spinocerebral tract, which is having an anterior as well as a posterior tract. Now, talking about an anterior tract, remember this is written over here posterior. I'll write over here anterior one, the function of anterior tract. The anterior tract helps in proprioception of the lower limbs. Okay. Same way, even the uh, posterior spinocerebral tract also will contain the proprioception of the lower limbs to the ipsilateral cerebellum. Okay, ipsilateral cerebellum. So together, I am telling you, the anterior spinocerebral tract as well as the posterior spinocerebral tract will be having the same function. Okay, of proprioception from the lower limbs. Remember, lower limbs. Okay. So next one, coming to the fasciculus gracilis and the fasciculus cuneatus. Okay, this is otherwise known as the tracts of Gall and Boda. Okay, now these two together, they will contain the proprioception, or you can say joint sense or vibration sense, even the stereognosis, 2-point discrimination, the conscious kinesthesia. All this will be by the fasciculus cuneatus as well as the fasciculus gracilis. Remember these two. Okay. So this was about the ascending tract. Now let's see a little about the descending tracts. So descending tract, we have, first I'll show you in the picture, we have lateral pyramidal tract and extrapyramidal tract. We have lateral corticospinal tract, we have an anterior corticospinal tract. And then under the extrapyramidal tracts, we have ribrospinal tract, We have reticulospinal tract, we have olivospinal tract, and lastly we have a vestibulospinal tract. Okay. Now remember a little details about the pyramidal tract. Pyramidal tract. They have derived their name actually from medulla pyramida, pyramids of medulla oblongata. Okay, which they pass through. So first one, we have a cortico spinal tract. Corticospinal tract, that is a lateral corticospinal tract, and a anterior corticospinal tract. So the lateral corticospinal tract, they help in controlling the conscious skilled movements, especially of the hand. Okay, like contraction of individual or small group of muscle, particularly those which moves the hands, fingers, and the fingers of feet, toes, anything. Okay, that's what happens with the lateral corticospinal tract. Anterior corticospinal tract, again, same as that of the lateral corticospinal tract. Same thing happens. That is, it helps in the in controlling the conscious skilled movements. Okay, conscious skilled movements, voluntary movements, especially of the hands. Next one, we'll see with the extrapyramidal tract, that is rubrospinal tract. Rubrospinal tract. Okay, before that, I'll just give you an extra information about the extrapyramidal tracts. They originate from the brainstem. Remember, they originate from the brainstem and they carry the motor fibers. Remember, motor fibers of spinal cord. Okay. Now, in a gist, I will tell you the extrapyramidal tract are responsible for the involuntary and automatic control over the musculature, like muscle tone, then coming to balance, even posture, as well as locomotion. These are being controlled by extrapyramidal tract. Now, coming to the rubrospinal tract, remember unconscious coordination of the movements. This is what happens. Uncoordination or unconscious coordination of the movements is by the rubrospinal tract. Okay. Now, exactly what happens is it plays the fine movements, fine control of hand movements. This is one of the important action of rubrospinal tract. Next one, coming to the vestibulospinal tract. Now, this helps in the unconscious maintenance of the posture and balance. Posture on balance. Now, this innervates the anti-gravity. Remember, this innervates the anti-gravity muscles. Now, what are the anti-gravity muscles? They are the flexors of arms and extensors of leg. This is what happens. And vestibulospinal tract, it helps in the unconscious maintenance of the posture and balance by innervating the anti-gravity muscles. Okay, now next coming to the tectospinal tract. This tectospinal tract, it will actually help in the coordination of the movements of the head in relation to visual stimuli. So controls movements of the head, neck, and the arms in response to visual stimuli. Okay, visual stimuli. Now coming to the reticulospinal tract, they are having two. One is the medial and the other one is the lateral. Let's see what happens to the medial one. So lateral one first we'll see. This is arising from medulla and the medial one arises from the pons. Remember, lateral reticulospinal tract arises from medulla, whereas medial reticulospinal tract arises from the pons. Okay. Now let's see the functions. These two. The first one, lateral, mainly responsible for facilitatory influence on the motor neurons, the skeletal muscle. Okay. Now it actually facilitate or inhibits the voluntary movement. It inhibits, I'll tell you, the lateral lecture inhibits the voluntary movements. Okay, and it because of that it increases the muscle tone. I'll repeat once again. Lateral reticulospinal tract, it inhibits the voluntary muscles or voluntary movements. Voluntary movements it inhibits, and because of that the muscle tone increases. Whereas the oh, I'm really sorry, it decreases the muscle tone. Just got confused. Yeah. So lateral reticulospinal tract, it inhibits the voluntary muscle, thus reducing the muscle tone. Whereas the medial reticulospinal tract, it facilitates facilitates the movements, and thus it increases the muscle tone. Okay. Here it is written little the other way, but remember this. What I said is lateral reticulospinal tract, it inhibits the voluntary movements and thus reducing the muscle tone. Whereas medial reticulospinal tract, it facilitates the voluntary movements, and thus increasing the muscle tone. So this was about the descending tracts. Next one, very important one, we're going to deal with is the Brodmann's area. Okay, Brodmann's area. Now this you have to keep in mind which area, where is the location, and what is the name. So I hope you can take a screenshot of it. The first one we are going to deal with is the 41 and 42. So the 41 and the 42, remember the location is in the temporal, and that is superior temporal gyrus. And the name is the primary auditory area. Primary auditory area. Okay. Next one is uh, area number 22. And that is temporal, located in the temporal. And this is auditory association area. Now, among all this, which is very important, this is important. Area number 44 and 45, which is nothing but the Broca's speech area. Broca's speech area. Broca's speech area. This is very important one. This has been repeatedly asked in few exams. Broca's speech area, motor, and that is area number 44 and 45, located in the inferior frontal gyrus. Okay. Now, area number 4 and 6, they're located in the front of the central sulcus, that is precentral actually. That is a motor area. 3, 1 and 2, that is behind the central sulcus. That is post-central, and that is primary somatosensory area. Coming 5 and 7, that is behind the central sulcus. Again, that is a somatosensory association area. And lastly, we have 17, 18, and 19. That is occipital, located in the occiput, and that is a visual area. So these two are very important one. You should remember. Okay. Broca's speech area, they are 44 and 45. Visual area, that is 17, 18, and 19. So with regards to the Brodmann's area, one more thing which you need to remember is area number 22, 39, and 40. And that is Wernicke's speech area. So Wernicke's area and Broca's area. So Wernicke's speech area is 29, 39, 22, 39, and 40. This is sensory. Okay. So Wernicke's area and Broca's area was being asked in few of the exams. So this becomes very important for you to know. 44, 41, 42, primary auditory area. 22, auditory association area. 44 and 45, Broca's speech area. 4 and 6, that is motor area. 3, 1 and 2, that is primary somatosensory area. 5 and 7, that is somatosensory association area. 17, 18, and 19 becomes the visual area. Okay. So coming to the embryological part. This is very important. This was asked many, in many AIPGT exams. This was asked. So the first one is the neural tube. Neural tube forms a CNS. Remember, neural tube forms a CNS, that is the brain and the spinal cord. Very important one. Okay. Now, if the anterior, you can see over here, we have an anterior neuropore and we have a posterior neuropore. Now, we have already said the neural tube forms the brain and the spinal cord. Now, remember that this both, the anterior neuropore and the posterior neuropore, has to fuse together. If this is not closed, if the anterior neuropore is not closed, uh, we have a condition known as anencephaly. That is, the vault of the baby will not be there. Vault of the head will not be there. It will be open. Okay. Now, basically, the anterior neuropore should close by the day 25. By the day 25, it should close. Day 25 after fertilization, it should close. Okay. Now, but in the same way, if at all the posterior neuropore is not closed or not fused, it causes spina bifida. And remember, this should close by day 28. So anterior neuropore should close by day 25 and the posterior should close by day 28. If it doesn't close, we have anencephaly. If anterior neuropore doesn't close, we have anencephaly. And if posterior neuropore doesn't close, we have spina bifida. Okay. And remember, the neural tube forms the CNS, that is the brain and the spinal cord. So this was something regarding the neural tube, the anterior neuropore, and the posterior neuropore. Coming to the derivatives of cerebral region. This is important. Important for you to know. So next one is the cerebral region, I will tell you, and derivatives. If you can just take a screenshot of this. Okay. So coming to the myelencephalon. The derivatives are medulla oblongata, caudal part of the fourth ventricle, and the inferior cerebellar peduncles. In one form, one slide, I've given you all the derivatives of the cerebral region. So it becomes easy for you to learn. Next one is the metencephalon. Now, from this particular region, we have the pons, cerebellum. We have middle part of the fourth ventricle and the middle cerebral peduncles. So inferior cerebral peduncles are from myelencephalon. Middle cerebral peduncles are from metencephalon. Now coming to the superior cerebral peduncles, they are from the isthmus rhombencephaline. Okay, and along with that, we have a superior medullary velum. So these are from the rhombencephalon or the hindbrain. Now coming to the midbrain, that is a mesencephalon, we have cerebral peduncles, we have tegmentum, we have tectum, and we have aqueduct. So these are from the midbrain or mesencephalon. Now coming to the forebrain or the prosencephalon. Prosencephalon we have two, that is diencephalon and telencephalon. Coming to the diencephalon, what we have is we have thalamus, we have metathalamus, we have subthalamus, we have epithalamus, caudal part of hypothalamus, and the caudal part of third ventricle. So these are the things which are there in the diencephalon. Coming to the telencephalon, we have rostral part of hypothalamus, rostral part of third ventricle, cerebral hemispheres, lateral ventricles, and cortex. Plus, we have corpus striatum. So these are the derivatives. Now, we need to read it again and again. Then only we'll remember this. If you want, you can take a screenshot of this. Myelencephalon, metencephalon, and isthmus rhombencephalon. These are nothing but a part of rhombencephalon. There is a hindbrain. Then we have mesencephalon or the midbrain, and finally we have prosencephalon or the forebrain. Okay, and forebrain has two parts: diencephalon and telencephalon. So this was regarding the derivation. Thus we have completed the most important topics of the head and neck as well as neuroanatomy. I hope you might have understood. Please go through the chapters again and again so that it remains in your mind.